Hi everyone, I'm Angela Ballantyne and this is a quick video introduction to the concept of vulnerability in relation to research ethics. Today I'm going to be talking about the ethical concept of vulnerability, and it's quite a high level overview of how we think about vulnerability in relation to research ethics. This is not supposed to be the equivalent of an analysis of policy or regulation or law in the specific jurisdiction that you're obviously working in. Hopefully this background ethical discussion of the ethics will help you interpret and understand better the local regulation in the area that you're working in. So today we're going to look at the history of discussions of vulnerability in research ethics, define vulnerability, and look at some of the options in relation to safeguards for protecting vulnerable populations in research. As I said, this isn't a discussion of policy or regulation, and in part that's because the specific policy is going to vary depending on which country you're working in, which state. Sometimes local hospitals or IRBs will have specific policy or sometimes specific interpretations of policy. So it's difficult to speak to, all of that variety. Today I'm going to draw heavily on this particular document, which is the International Ethical Guidelines for Health-Related Research Involving Humans, that's been produced by the Council for International Organizations of Medical Scientists in collaboration with the World Health Organization. This latest revision was produced in 2016, and the process of revision involved a really substantive consideration of the issue of vulnerability. So I think it's a great document for us to work from in 2020. It's one of the most kind of up-to-date resources and one of the most thoughtful considerations of vulnerability in relation to research. So if we look at the history of concern about vulnerability, we can see, first of all, that historically vulnerable populations were involved in research, but often without their specific consent. And so certainly with the kind of modern lens looking back on those historical cases, they're often thought to be exploitative of those vulnerable populations. And often it was for the convenience of the researchers that these populations were chosen, not because the research specifically focused on a health need relevant to that population. So some examples include the Tuskegee research in the United States, what we have a case in New Zealand that we refer to as the unfortunate experiment, which involved research on cervical cancer, and the research that was conducted by the Nazis on prisoners of war during the war. With, as I said, with the benefit of hindsight, we often look back and think that these cases were exploitative and problematic. Historically, also, prisoners were used very regularly in research, again, because they were a very convenient population from the researcher's perspective. So as public perception around these issues started to shift, there were often inquiries around these historical abuses within research ethics. So for example, there were the Nuremberg trials that were conducted to investigate Nazi research on prisoners of war. In the United States, there was the Commission for the Protection of Human Subjects of Biomedical and Behavioral Research, looking at the Tuskegee research in the United States. These kind of public processes of inquiry resulted in a range of new regulation, new reports, and really sort of the birth of research ethics as a discipline with a whole new set of rules. And those were really designed with these kind of historical abuses in mind. So that was very much at the forefront of the author's mind when they were writing these documents. And that's important to understand, that the history of research ethics didn't occur because people sat down and thought, what are all the benefits of research and all the risks and how do we balance these? These documents came about because people were thinking, this really awful abuse has happened and we need to make sure it never happens again. So a lot of these documents were quite protectionist because a primary focus was protecting vulnerable populations from harm in research. Now, that led, the sort of protectionist stance actually led to researchers moving away from working with vulnerable populations in research to the extent that it became problematic. And that's because we ended up with a situation where researchers, particularly in relation to pharmaceutical research, relied overwhelmingly on middle-aged white men to be research subjects. Now that's problematic because research is really important to generate clinical knowledge that then underpins medical care. And if all the research is being conducted with one particular subpopulation, that's going to not give us sufficient information about the safety and efficacy of those interventions for other populations. For example, women, pregnant women, children, older adults who might have comorbidities, ethnic minorities, people of colour. So there's a real issue regarding justice if vulnerable populations are excluded from research, even if that's done with the best of intentions and even if it's done to protect people from harm. So we're now in a phase where we're focusing more on balance. So there's been an increasing number of efforts starting in, say, 1993 in the United States with the National Institute of Health's Inclusion Act, which really focused on the inclusion of minorities and women in research. There's been subsequent efforts to advocate and in some cases require the funding for research with children. Efforts very recently to include pregnant women in research and to include prisoners in research again. The real difference that you need to understand in terms of the history is that historically, vulnerable populations were included in research for the convenience of researchers. The modern approach is to try and include vulnerable populations in research in a way that's safe, that protects their interests, and where those research with those groups is necessary to generate medical evidence and medical knowledge for the benefit of those groups, and where you really couldn't get that knowledge with any other way without including that vulnerable group in research. Okay, so a definition. So in the early 2000s, the approach to defining vulnerability was to identify groups that might be vulnerable and really class that entire group as vulnerable. And Samia Hurst wrote a great paper in 2008, which reviewed a range of different regulatory documents and pulled together all of the different populations that were labelled as vulnerable. And you can see this kind of growing and really extensive list that kind of unmanageable, to the point where so many different groups might be labelled as vulnerable and then potentially excluded from research unjustly, or have a range of protections applied that may or may not be necessary. So we have moved away from labelling whole subgroups or communities as vulnerable, and we now have an approach to vulnerability based on the work of Florencia Luna and others that's much more context specific and layered. And the idea here is that vulnerability depends on the context, and also that vulnerabilities may be layered. So vulnerabilities might relate to my decisional capacity, my education, my wealth, for example, my gender. And so we need a really much more nuanced account that can take account of those multiple elements of vulnerability. The Declaration of Helsinki, which is an important international document regarding research ethics, defines vulnerability as where there may be an increased likelihood of being wronged or incurring additional harm. And the CIOMS document defines vulnerability as persons who are vulnerable where they might be relatively or absolutely incapable of protecting their own interests. And this can be due to an impairment in decisional capacity, so their ability to make decisions about research participation, education, resources, strengths, or anything else that's required for us to protect our own interests. So we're vulnerable when we have less capacity to protect ourselves. It's really important to note, and CIOMS does a good job of this, of noting that persons can be vulnerable sometimes by features of circumstance or the social context in which they're living. For example, in ways that might make others around them less vigilant or sensitive to their personal interests. And this can happen when people are marginalised, stigmatised, or face social exclusion that puts them at increased risk. So for example, I'm female. In some social contexts, that may correspond to no vulnerability in relation to research. But if I was living in a community that was very patriarchal, where it was not accepted that I had the right to make decisions for myself, and my husband, for example, made decisions on my behalf, either around property, around children, or for example, my participation in research, then I would be vulnerable in that social context. So this is really getting to the idea that vulnerability is context specific, and that when researchers or institutional review boards or research ethics committees are looking at vulnerability, it needs to be on a case-by-case basis, focusing on the specifics of the research team, and the community in question. So with that in mind, what kind of safeguards can we use to try and minimize the harm to vulnerable groups when they participate in research, and to mitigate those harms where they can't be minimized? So the starting point is that depends on the nature of the vulnerability. So our response is going to depend on what the source of vulnerability is. And here are some strategies, again, these outlined in the COMS 2016 guidance, and we'll go through these one by one. Okay, so a lot of advice in relation to including vulnerable populations in research focuses on minimal risk, and sometimes minimal risk limits, particularly where the research doesn't offer any personal therapeutic benefit to participants. So often there'll be a requirement that vulnerable groups can be included in research, but only if it's minimal risk, or in some cases a minor increase over minimal risk. So risk and minimization thresholds are one form of safeguard. Proxy permission is another. This would apply, for example, if you had adults, for example, that didn't have the capacity to consent to research themselves. Those might be adults that had been in an emergency situation, were unconscious, adults that were suffering neurological conditions or degenerative conditions, had Alzheimer's or Parkinson's, had lost the capacity to make decisions for themselves. Proxy permission might involve, sort of as like a supplement to the consent process, so might involve getting additional permission from a family member, from the patient's primary caregiver, or head of the clinical team, or some legal representative. So it's having consent or permission from somebody other than the patient themselves for that person to participate in research. It's an additional check and balance from someone who has the patient's best interests at heart. Almost universally, there's a requirement that if vulnerable individuals or groups are to be included in research, it must be the case that the research is designed to address a relevant health need for that community. Sometimes this is framed more strongly in terms of research can only go ahead if it would be impossible to get that knowledge, to generate that knowledge without involving that vulnerable group. Now, obviously, if you're interested in the use of condoms amongst sex workers, it's going to be very difficult to get that knowledge without recruiting that group, even if that group in that circumstance, in that jurisdiction, vulnerable. For example, if sex work is illegal. If you want to understand drug use in prisons, you have to recruit prisoners to participate in that research, because you can't get that knowledge any other way. Again, it's not plausible to do research in adults and then just translate those findings to children as though they're small adults. Their physiology is quite different. So if you want to understand childhood leukemia, you need to involve a pediatric population in that research. So this limiting factor says that it's okay to do research with vulnerable groups so long as the research is designed to address a relevant health need of that group, and that group is really going to benefit from the medical knowledge that's generated. Fourth, we can promote voluntary decision making. So this is speaks to the idea that research requires consent, and that consent needs to be voluntary, and we can put efforts into communicating. So that might involve having translated documents. It might involve having cultural advisors to either help with recruitment, to explain the research to certain communities, or to help design the participant information sheet. Material should be produced in a way that discloses the information and explains the information about the research in a way that's designed to meet the needs of participants. This might mean that it's age appropriate, it includes comics, the language is written at a certain level that's easy to understand. It also might mean that there's health advocates or experts in supported decision making who can help participants meet the requirements for consenting to that research themselves. And finally, there's a really growing interest in community engagement and co-design. This speaks to the idea that if vulnerability is an impaired capacity to protect our own interests or the vulnerable group's interests, Protecting those interests is really at the heart of these safeguard measures. And the trouble is that sometimes researchers, if they're not involved with that community, might not be able to anticipate what the interests or concerns or risk factors for that community actually are. And the only way to really get a really good understanding of that is to work with the community themselves, ideally from the point at which the research is conceived, all the way through the kind of design process. So not just at the point when you want to recruit members of that community. Certain communities, for example, Indigenous communities, have been really over-researched, often for the benefit of the research team, and it's often been a real struggle to translate that research back into interventions that have improved the health of Indigenous communities. So many countries now have requirements that if researchers want to do research on health inequities, on conditions, health conditions that affect Indigenous communities, they need to consult and collaborate with communities to design that research in a way that really meets the needs of those communities. And co-design obviously takes kind of community engagement one step further and makes the community a participant and researchers themselves in the process. All right, so in summary, we've talked about the history of vulnerability in relation to research, looking at exploitation, protection, and balance, and those different phases as we've moved historically through those phases from exploitation to protection to now focusing on balance, where we try and include vulnerable groups back in the research agenda. We've looked at definitions of vulnerability, really coming down to the idea that vulnerable groups are more likely to incur harm or be wronged because they have an impaired capacity to protect their own interests. We've noted that the definition of vulnerability shouldn't be applied to entire groups, that vulnerability should be interpreted in a way that is context specific and layered. And then we've talked about a few different strategies for minimizing harm and safeguarding vulnerable groups. And the really primary requirement here is that research should address the health needs of participants. That one way of finding out if your research addresses the health needs of participants is actually to engage with that community and find out from their perspective what their health needs are, and that there are requirements around minimal harm limits and sometimes proxy consent and supported decision making. So I hope this has been helpful in terms of introducing you to some of the broad ethical concerns regarding vulnerability in research. Thanks.